Chapter 8, Video 6. In this video, we're going to talk about atrial fibrillation. The term fibrillation means quiver. So when we think about fibrillation, whether it be atrial fibrillation or whether it be ventricular fibrillation, fibrillation means quiver. So that basically means these atriums are quivering, okay? There's hundreds of atrial impulses from different locations that are firing all at the same time. So remember we talked about those different foci? We have multiple foci that are irritated and they're firing all at the same time. The atria actually depolarize, but they're not depolarizing as a unit like they usually do, but they rather depolarize in small sections, and it causes the atrium to wiggle instead of contract. And the AV node is actually bombarded with all of these impulses and simply cannot depolarize fast enough to let them all through. So the AV node becomes overwhelmed because it's just hit with tons of impulses, okay? So every now and then one of these impulses get through and it provides a QRS, but not all of them get through. It can't even control how many gets through because it's so overwhelmed. With atrial fibrillation, this is an irregular rhythm. And again, one thing that we need to think about is the atrium are actually wiggling instead of contracting. With this atrial fibrillation, we have an atrial rate of 350 to 700, which is astronomical. Again, the ventricular rate is going to vary. It's going to depend on how many signals this AV node lets go through, okay? AFib with a ventricular rate greater than 100 is said to have RVR. RVR stands for rapid ventricular response. The ventricular rate is the same as the heart rate. So always remember, when we're talking about the ventricular rate, we're actually talking about the heart rate. So if with AFib, if that AV node lets more than 100 get through, then we have RVR, which is a rapid ventricular response. With atrial fib, it's irregular. We do not have any P waves. There's no P waves present at all. And because we don't have any P waves, there's no PR interval. So we can't calculate the PR interval. That's irrelevant because it's not applicable because we don't have a P wave. The QRS, again, is less than 0.12 seconds, which tell us that this rhythm is not happening in the ventricles, that it's happening in the atria or somewhere along the pathway in a different area. There's different causes, which could be a myocardial infarction, lung disease, valvular disease, hyperthyroidism. The adverse effects here, one of the huge ones that you need to think about is blood clots, and I'm going to explain that in a second. But we can have decreased cardiac output, blood clots that can cause a stroke, and we can also have a pulmonary embolus. AFib can cause a loss in cardiac output because remember when we talked about the heart and the cycle and the atrial kick earlier in the semester, the atrial kick accounts for 15 to 30% of our cardiac output. And with atrial fib, we lose that atrial kick because the atrium are just sitting there quivering. So the atrium's not contracting and squeezing like they should. They're just quivering. So we lost that atrial kick. So gravity is taking blood down into the ventricles, but some blood is being left behind. Not all of the blood is being expelled from the atrium because we've lost that atrial kick and the atrium are just sitting there quivering. So that blood that gets stuck in the atrium, it just sits there and it sloshes around and it can actually clot. And that's why we're at risk of clots, because that blood's not moving out of the atriums. It's just sitting there. So one of the big things that we see with this is blood clots, strokes, myocardial infarctions, pulmonary embolisms, because that blood is just sitting there clotting. And it's sloshing around. So that's one of the huge risks that's associated with atrial fib. With atrial fib, we definitely need to focus on treatment. You will see questions about this. That blood flow is stagnant, clots can develop. So the goal is to restore that atrial kick by converting this rhythm back to sinus rhythm. One thing that we have a risk of, when we convert that rhythm back to sinus rhythm, we can dislodge a clot that has formed in that atrium, and we can send it out into the circulation, which in turn can cause a stroke, a heart attack, a myocardial infarction, or a pulmonary embolus. So remember that when we convert them back to sinus rhythm, one of those clots could dislodge and move and cause a problem. If they have been in atrial fibrillation for less than 48 hours, we want to convert them back to sinus rhythm. We can do so by doing this with Digalis, calcium channel blockers, beta blockers, amiodarone, or cardioversion. Okay, and this is important. The timing here is important, and you need to understand this, because if they have been in atrial fib greater than 48 hours, the risk of the blood clot is greater, because that heart has been quivering for much longer and much more blood has sit in there and pooled, and you've given more time for that clot to develop. So what they'll do is they'll put patients on an anticoagulant, a blood thinner, to bust these clots up for 2 or 3 weeks, and then they will cardiovert, okay? In emergencies, they can do heparin or transesophageal electrocardiogram to rule out any atrial clots. So they'll go in and they'll look and make sure that they don't have any clots in there before they do anything, if it's an emergency. But if a person is in atrial fib and they've been in atrial fib for less than 48 hours, they'll go ahead and work on getting them back in rhythm. But if they've been in atrial fib longer than 48 hours, they're going to treat them with blood thinners and rule out any clots before they do any form of treatment to get them back into a regular rhythm, because they don't want to push any clots out. Now, you're probably sitting here thinking, well, how do I know how long this person's been in atrial fib? How do I know they've been in atrial fib they may have been in atrial fib for a week and I didn't know it. If you don't know, you're going to treat them like they've been in atrial fib for longer than 48 hours. However, if you are at the hospital working on them and they've been on a monitor for the past 3 or 4 days or a week or 2 weeks, you know they've been in a normal rhythm and they just converted into atrial fib, then that is when they will go ahead and they'll go ahead and cardiovert them back. But if they come in randomly and you don't know, they're going to treat them like they've been in atrial fib for greater than 48 hours, okay? And looking at this slide, this kind of shows you what happens is you can get a blood clot that forms in here, and then it's pushed out, and it can go to the brain, and it can block one of these vessels and cut the oxygen and blood supply off. So not all strokes result from bleeding. Some strokes result from a blood clot that blocks the flow and the brain can't get oxygen, while other strokes, the vein ruptures and blood bleeds out. But in this case, it would be a result from a clot. Looking at this strip, oh my goodness, here we go. I've got something else. This is not my perfect strip. What do? I ask myself the same 5 questions that I ask myself on every single strip that I will ever diagnose. Is there QRS complexes present? The answer here is yes. They look pretty normal. Is the rhythm regular or irregular? If I march this out, I'm going to determine that it's irregular. The heart rate itself is 65 to 100 with a mean rate of 90. We do not have P waves. We don't even have flutter waves. We have nothing. This is fibrillatory waves, okay? We do not have a PR interval. The QRS is the QRS is 0.10. So we know we're dealing with atrial fib because it fits the criteria. If you have any questions, please let me know.